Well, welcome everybody. I'd like to invite you and welcome you to Horses and Human Research Foundation's very first webinar. My name is Phil Tedeschi. I am a faculty member and a professor at the Graduate School of Social Work at the University of Denver and the executive director of the Institute for Human-Animal Connection. I'm also honored to serve as an ambassador for the Horses and Humans Research Foundation and the facilitator of this very first webinar. So enough about me. I want to turn this over to introductions to our presenter and panel members. As a reminder, the focus of this webinar is on the specific research study entitled Changes in Dynamic Trunk and Head Stability and Functional Reach After Hippotherapy. You can see the abstract that will be attached to this, and you'll hear in much more detail the research itself. So I'd like to turn it over and ask our panel members to introduce themselves, and Tim, we'll start with you.
Well, my name is Tim Shurtleff. I'm an occupational therapist, and I'm on the faculty at the program in occupational therapy at Washington University School of Medicine in St. Louis. And we started this study in about 2005, published it in 2009, and I plan to tell you a lot more about it. I'm also a registered therapeutic riding instructor and driving instructor with PATH, and in addition to that, I do hippotherapy with children with disabilities as an occupational therapist.
Great, thank you. Victoria, let's go to you.
Okay, I am also, I'm a physical therapist and went back to graduate school and got a PhD some years ago, and my research was focused on looking at the interaction between the horse and the rider. Did some research for my master's degree and then went on for my PhD and did some modeling, mathematical modeling of the horse and the rider, looking at the coordination and changes in the coordination between the horse and rider over time. And right now I'm practicing physical therapy in Michigan and enjoying my horse. And that's all I'll say.
Great, thank you very much. And Kitty, let's go to you.
Thank you, Phil. I'm Kitty Stallsberg. I'm from Lyme, Connecticut. I've been in the field 28 years. My background is in animal science. I am a master instructor. I have been able to practice in the field as the program director for a large therapeutic riding program, High Hopes, in Old Lyme for 17 or 18 years, and now I've transitioned into an executive director role. But I have a strong affinity and support for PATH and the work that we do, and am proud to be also as an ambassador to Horses and Humans Research Foundation, and enjoy supporting the delivery of service and supporting those in our field that are learning how and joining the field. So looking forward to this.
Thanks for bringing your expertise today, Kitty. Erica, how about you?
Hi, I'm Erica Gergley. I am a clinical psychologist in Kalamazoo, Michigan. My doctoral research focused on equine-assisted therapies. I've been a member of EGALA since 2008 when I earned my EGALA certification. And I've been a member of Horses and Humans Research Foundation, the Scientific Review Committee, since 2013.
Great. Well, thank you for your introductions. So the way we're going to do this now is we're going to turn this over to Tim, who's going to be talking about his work, and we'll hold questions until the end of that presentation for the most part, and then we'll come back and talk to all of our experts, and they'll each have questions for Tim, and we'll have a lively discussion after that. So, Tim, I will turn this over to you, and if there is anything from the panel members that is a burning question, please just alert us that you have a question that needs to be answered during the presentation. Okay, thanks very much. Tim, it's all yours.
Okay, you should now be seeing the first page of the PowerPoint presentation. Is that correct?
Yes.
Okay. The title is Changes in Dynamic Trunk Head Stability and Functional Reach After hippotherapy. This was a study that was funded by the Horses and Humans Research Foundation. I'm going to tell you a little bit about how we got to there and then the results that we achieved. I'm just going to start with the pilot study that was the basis of the grant that the HHRF gave us to continue the work. The site, it was published in 2009 in the Archives of Physical Medicine and Rehabilitation and is available from that journal. So if you'd like to read the entire article. So just initially, let's just start out by some definitions. And basically, what is hippotherapy? And we've abbreviated it as HPOT throughout the presentation just for brevity. Hippos is a Greek word for horse, and hippotherapy is literally defined as therapy using a horse. And the problem that we were addressing is that hippotherapy is expensive. There's lots of anecdotal claims. Not a lot of objective evidence, although there's more now than when we actually produced this article. But insurance funding, especially now for kids with disabilities, is really predicated on efficacy evidence nowadays. And so we were trying to do a study where we could develop some evidence. Treatment strategy in the context of physical therapy, occupational therapy, or speech therapy. And the equine movement is considered a treatment strategy within that context of the barn, the farm, and the psychosocial environment. And I want to be really clear that this is not a riding lesson. It's a one-on-one treatment session from a professional licensed therapist who is directly working with the patient and not teaching a riding lesson to that patient. My PowerPoint is not progressing. Okay, the purpose of this pilot study, we had two purposes in mind. We really wanted to develop a way to measure trunk and head stability changes after PT or OT using hippotherapy. And we wanted to apply that measure in a study of a pilot sample of therapy clients, and we specifically looked at clients with cerebral palsy. So our study participants, we had 6 children, and this is a pilot study, 6 children with spastic diplegia CP, and this is the type of cerebral palsy where the legs are more involved than the arms. Average age of 10.5 years, they needed to be able to sit upright unaided. That is, we didn't want to have to hold them on the horse. They needed to be able to take direction, which really meant to us that there weren't any other psychosocial or mental retardation issues that kept us from being able to give them clear direction and have them respond. They also couldn't have had Botox or surgery within a year that would have affected our outcomes. And we wanted kids that had no previous hippotherapy or any horse riding experience in the past. So this is what it looks like. This is what treatment looks like for those that have never seen it. And we had 12 weeks of 45-minute OT-PT treatment as part of the study. And they were conducted by a state-licensed registered therapist that was registered with NARA and also had experience in training with the American Hippotherapy Association. They needed to be a PT or an OT. There was a support team of leaders and sidewalkers, and as in any effective therapy program, they had a customized treatment plan based on an evaluation of them, of each patient, and that was individualized to the patient. But the common denominator among all of them was they spent 30 to 45 minutes mounted in 3D rhythmic motion from the horse. And if you think about that, a horse takes about 100 steps a minute. So on a 45-minute session, they had somewhere between 3,000 and 5,000 horse steps. And each step moves the pelvis, and it challenges their postural stability. So that's what we wanted to do, is measure the effectiveness or the effect of that on their ability to keep their head and trunk stable after they'd experienced this treatment. We developed a test, which is a motorized barrel. And it's a very simple barrel. It's not a horse simulator. It only moves in one dimension, back and forth. It moves about 16 centimeters. But it provides us with a replicable testing challenge. So we are testing it with exactly the same motion before the 12 weeks of treatment and after the 12 weeks of treatment. We also tested them in 2 positions. We had them sit astride the barrel and side sit. So we tested really 2 dimensions of the 3 dimensions that horses move in. And for safety, we had spotters on both sides, just like as if they had sidewalkers at the barn. For data collection, we have a motion capture system in our laboratory where we put 24 reflective markers on the anatomical landmarks. We had 6 digital video cameras around the lab. We collected data 60 frames per second, and our system measures 3-dimensional position to a precision of 0.5 millimeter. Our barrel moved 1 hertz, means one cycle per second, and we tested 2 15-second trials for each position, and we tested both before and after the 12 weeks. This is what it looked like in the lab with a real patient. We had them hold a toy or a ball in front of their abdomen so that they would capture their hands so that they wouldn't reach out with a protective extension. They wouldn't grab the barrel, kind of kept their hands out of the way of the markers also. We used the markers, as I mentioned, for analysis. If you look at the main ones we used were one at the top of the head. We called that the vertex. C7 is the top of the trunk with the 7th cervical vertebrae. T10 is pretty much the middle of the trunk. S2 is the bottom of the trunk, and we put markers on the barrel so that we would have a reference point for the actual movement. As outcome measures, we used 2 variables. One was the head angle, which is really the line from the vertex to C7, from here to here. And then we also, looks like I skipped a slide here, we used anterior-posterior translation, is how well they were able to keep their head still while their pelvis was in motion. We measured that at the top of the head. We called it the Cyclops eye, which was a marker we calculated between the eyes. The top of the trunk, the middle of the trunk, bottom of the trunk, as I mentioned. So that if we calculate head angle, if we extend the markers on the horse and extend the marker between vertex and C7, we create an angle, and we measured this angle. If you remember the picture that I just showed you, it showed the boy really flopping around, and this is an actual representation from the computer program of how he actually moved during that test that you saw the video of, and this was prior to his 12 weeks of intervention. This is what he looked like afterward. You see a difference in the angle, and also in the translation. So when we actually calculated the difference, things that changed, if you look here, you see in this graph, this is the angle of the head to the horse to the barrel, and this was movement. So every one of these loops is a cycle of movement from the testing barrel. In pre-test, he had a range of motion of 89 degrees, so almost 90 degrees. So he went from 7 degrees to 96 degrees of movement of that angle. And we also used this range of motion of 89 degrees and a standard deviation, which is really the average movement of all of the measurements. So we found to be a really good measure of outcomes. This is what he looked like after 12 weeks. And you can see that his range of motion is half, his movement was half, his standard deviation was half. We called that movement variability, standard deviation. And for a comparison point, a child without a disability, basically what this says is we're moving in the right direction. We're not there yet, but we've made some pretty significant progress to be able to control the body much like the child without a disability the same age. This is the same movement, but I've put trajectories on it so you can more easily see the translation. And if you actually look here, it's the size of the loops back and forth that we're measuring. And this is the translation of the vertex and translation of the top of the trunk, which we found to be our most significant points of reference. And again, afterward, you can see a very significant visual change in the size of those loops, which indicates how much greater control this child had gained in his control of his trunk to the very same motion that had perturbed his pelvis. When we averaged all 6 kids in the study, their average movement was represented by this line along each of these points up their trunk, from the top of their head to the top of their trunk. And this line represented a standard deviation, which is really how much variability there was between all of the kids. After the intervention, this blue line was the average of the kids, and so all of them, on average, had about half the amount of movement, which meant they had twice as much control of their trunk after the 12 weeks of intervention of hippotherapy. The green line represents the group of people we had without disabilities as a comparison point. And as I look further at this, this is what we defined as the improved dynamic trunk and head stability, this difference between the pre-test and the post-test. Now, what was interesting is when we looked at statistical significance. The statistical significance here, the pluses represent the changes between cerebral palsy, people with cerebral palsy, and the changes and the people with cerebral palsy and the green line, which is the group without disability. What's also interesting as we go forward is that before the intervention, all of these points were significantly different. But after the intervention, we found that at the trunk, top of the trunk, there was no longer a significant difference between these 6 kids and the comparison group without disabilities, which was a pretty exciting outcome to get. So as we go forward, we reached these conclusions from the pilot study, that basically these 2 paragraphs say, the first one says that this method works. The second sentence says that we showed a difference between pre and post, with kids that had experienced 12 weeks of hippotherapy. So we approached the Horses and Humans Research Foundation when they offered their first grant in 2006 and wrote a grant, and they agreed that this was worth carrying this forward. So what we did is by the grant that they provided us, we were able to add to the study. So we added another group of 11 children with spastic diplegia CP. We also added 8 age-matched, typically developing children as a comparison point. So we had 11 children now instead of 6, as we had in the first study. The other thing we did is we still used the pre-post, but we added a follow-up period. We called that a washout period. So we tested them before the intervention, we tested them after the intervention, and then we tested them 12 weeks later after the intervention ceased, because we wanted to see basically how much of that improvement stuck. Whether they were able to maintain the improvement or whether they would lose it after no longer riding horses for another 12 weeks. We also added an upper extremity functional reach test because we really wanted to see whether this extra stability would help them to be able to do more things with their arms. Given a similar type of analysis, these are the results from the 11 kids that were in our Horses and Humans group. We started out more impaired. In the pilot study, the kids averaged about 12 centimeters, but in this group, they were more impaired. Their average movement along this line was about 16 centimeters. After the intervention, this white line represents how much improvement they achieved. We used the same line of our group of without disabilities, and this is a new group of the age-matched group. And what was really interesting to us and really also exciting to us is that this red dotted line, which represents the washouts test after 12 more weeks. And basically it says that they improved about the same amount as the group in our pilot group, and it all stuck. They didn't lose any of this ability. So it's really nice to know that the motor improvements that were gained on a horse for 12 weeks stayed with them an additional 12 weeks. This was the upper extremity functional reach test. Child, basically, we set a target at the height of his shoulder, and an easy reach was he didn't have to bend forward. We just set it the distance that he could reach with sitting without bending forward. We also had a extended reach where we moved it 10 or 15 centimeters, depending how large the child was. And we had them reach both forward and to the side, to both sides. Forward with both arms, into both sides, to see whether they're really able to improve their control of their upper extremities as a consequence of having improved their trunk control. Results for that test was we defined a reach path ratio, which is really the difference between a straight line from their thigh, where they rested their hand on their thigh, and then raised it up to the marker. And that's all the test was, is how quickly and how efficiently they could move their hand from their thigh to the target. Reach path ratio is the difference between the actual path they followed and a straight line. And we found that the reach path ratio reduced, which means that they were able to move more efficiently. we also found that they were able to move more quickly because the elapsed time from the pre-test to the post-test just 12 weeks later it continued to improve. But this is really kind of the bottom line. This is a little girl who was in our second study. She was 11 years old. She walked with a walker her entire life. On the last day, I went out to the barn I tried to see all the kids on their last day. And she was coming out of the barn, and she called me and asked me to come over, and she wanted to show me something. So she stood there in her walker. This is actually in our laboratory, this picture, because she came again to help to do a video with us. But she stood there in her walker, and she kind of stabilized herself. And she put her arms up in the air, and she stood there for 20 seconds. And she was so excited that she was able to do that. But I really didn't get it. Her mom called me over, and she says, "Tim, you really don't really understand. She's never been able to stand up without holding on before. And she never could tall kneel, and now she can." So this is the difference that we're really showing with these changes that we're making. So we had another project that we did with our horses and humans data. Everything I showed you so far with anterior, posterior movement. Remember, I said that we also tested kids in a lateral and side sitting on the barrel. And so results from that study, looking at all of our lateral movement, again, we had a group of our kids without disabilities to compare to. Changes were not extreme, but they were shown. We were able to show that some significant changes also in the lateral direction. Basically, because the horse movement is actually more extreme in the anterior-posterior direction, it's not surprising. But the improvement occurred more in the posterior direction than in the lateral direction. But just to show that improvement occurred in both directions. Our statistical results are kind of interesting. Between our pre versus follow-up visit, post versus follow-up visit, pre-post, again, comparisons, we had a lot of really significant changes. I'm not going to go through a lot of the detail here. It's all expressed in the paper, and I don't think we want to go through all the numbers, but just let you know that there's a lot of significant improvements that occurred that are statistically significant, that we can say some real change occurred. Another statistic we used was effect size. Now, effect size is defined really as how much change can actually be observed. And just point out that effect size of more than 0.8 is defined as really grossly observable. And you start looking at some of these effect sizes we see between our pre-test and our follow-up visit, and our pre-test and our pre- and post-tests, we have effect sizes that are either medium effect or grossly observable all the way across. So we're really able to say that these probably are clinically significant changes that we're able to measure. So there's some limitations of the study. We really didn't have any true functional or occupational outcome measures. We really measured at what we call an impairment level. And, of course, we can extrapolate or hypothesize some functional outcome, but we didn't really measure any actual functional outcome. The sample sizes, they're perceived as small, but when we actually did the study of the statistical study to look at our the required number that we needed to have power, statistical power, based on a pilot study, that calculation only said we needed 2 kids, but nobody would believe a study that had 2, and so we actually shot for 12 and ended up with 11. There really isn't a control group, so this really isn't a randomized clinical trial. That's something that we need more of in studying hippotherapy and outcomes. This kind of summarizes the lateral movement data that I showed you earlier, and this is a picture of from our computer program of, see, the length of the trajectories here are half as much post, and also in 3 months later, they're in our lateral movement, they're still about the same. So again, a single case shows pre, shows post, shows follow-up visit, very similar when we actually summarize all the kids together. How are we on time? I haven't really been watching the time. How far would you like? I have one other little case study I'd like to show. Philip, can you give me a hint on where we are?
Can you
so
hear
I'm
me?
not hearing anything. Yeah,
Tim,
I can
keep
now.
going.
Okay.
Yes.
So I had a single case study. I had an opportunity. It's actually the same boy that I showed the video of. His parents thought that this was so effective for him personally that they kept him on. We completed the study. We paid for his treatment. And they said, we want him to stay. So they actually had kept him. I heard that he's actually still out there now 5 years later. And he's now in a therapeutic writing program. He's graduated from Hippotherapy, but he is now writing independently, and he's really enjoying himself. But I had an opportunity 9 months after the initial study to have him come back to the lab. I asked his folks if they'd bring him back and see if we could test him and see what kind of long-term effects we could see. So I'm going to show you some results here. This is one of the ways we analyze the data, and if you look at this graph, you see this very regular brown curve that runs through it. That's the movement of the barrel through about 7 or 8 movement cycles. And the other two lines are the top of the trunk and the top of the head. So you can see that his head's flopping around quite a bit more than the movement. And this is the actual thing that you saw on the video earlier on, where he kind of flopped forward and back and flopped back and forth. In his post-test, 3 months later, at the end of the study, this is what his cycle looked like. You can see a couple of things here. One is the cycles aren't quite as deep, but you can also see that there's a lot of movement of the entire movement up and down, which means his body was leaning forward and back as he was reciprocating. 3 months later, you see a difference here. The total set of graphs flattened out, and we actually identified a second variable, or a third variable that we hadn't even thought of before, and that was body sway. The reciprocating motion you see is really that response to the movement of the barrel. But this is a kid who had a hard time just sitting upright without falling over. He could do it, but sometimes he really leaned forward and back to try to control himself. So we laid some trend lines over these curves, and you can see how that his body, as he was leaning forward and back, sort of followed a fairly long cycle. In his post-test, you can see that the cycle got from the peaks to the valleys got longer, which means it was slower. In his follow-up, it completely flattened out. So he gained, with 6 more months of treatment, he gained more ability to control his trunk. So he not only was better able to control his response to this reciprocating motion of that testing barrel, but he wasn't falling forward and back while he was doing it, which was really kind of interesting to see. Let me just skip that one. This is similar graph looking at the head angle as opposed to the translation. So what's significant is when I laid the trend lines on it, you can see that his pretest is this these big sweeps of movement of his head flopping forward and back, and you saw that in the video. His post-test, it's a lot shallower, but what's really significant is this dark line, which is the follow-up visit. And this would be the 9-month point. What's happening is when 70 degrees is really a vertical head, because the line between the top of the head and the trunk is about a 20-degree line. So when this line is at 70, his head is straight up and down, which means that he, instead of leaning forward and back and looking down and flopping all over the place, he's maintaining a vertical head as he goes through this test, which was kind of an exciting thing to see. This is another way to look at the data. This is really looking down on the top of his head. So this is lateral movement, and this is anterior-posterior movement of his pretest. You can see long loops without a lot of lateral sway. This is in the post-test, right immediately after the study, so it's 3 months later. You can see much shorter loops, so he's not moving as much, although he still does lean forward and back. But 9 months later, or 6 months after the second test, look what happens. He's basically keeping his head and trunk stable as any kid without a disability. And he really gained that ability to keep himself upright and stable, while this barrel is moving his pelvis around pretty radically. So that's kind of it, I guess. We're just kind of finish off here. So that's my contact information if anybody would like to talk to me about this further. And I think I'm done with the presentation, so we can talk about some of the responses from the panel.
Great. Thank you very much, Tim. And we're going to switch gears here and invite our panel, our experts, to give you their observations and ask you questions and provide some commentary. So why don't we start? We're going to start right here in order, and I think, Victoria, we're going to start with you.
Okay, thank you very much. I had a chance to read the article yesterday for the first time and had some takeaways as far as the first question that I'm supposed to address is, what are the critical takeaways from this research? And first of all, Tim, I think the research is very compelling, and I think you guys did a great job. I just want to make some comments here. I think what we can take away from this research is that we see an intervention that provides sufficient repetitions of perturbations to improve control in strength and coordination of the core or of our trunk. And this may translate to, this research suggests that this may translate to improved functional reach, improved stability of the head and neck in the sagittal plane, the forward and backward plane, and this may have impacts on other areas of these children's functional mobility. I think that's the main thing. Oh, and also that this change was maintained after 3 months of withholding therapy, which is, always a question that we as therapists, ask, what is going to be the overall long-term effects of a therapy, especially when it's withdrawn. The next issue of how do these findings inform equine-assisted activities for people with cerebral palsy or other movement disorders? Well, I think that a huge issue, and Tim definitely discussed this a bit, was the issue of repetitions, and that in a typical, therapy setting, we cannot provide sufficient repetitions unless there's, a home exercise program established and the patient is really compliant, which, is really hard with kids. And so, the horse provides these repetitions, in a relatively easy way, and, a motivating way for the kids. So I think that's really encouraging, and I think that, as therapists doing equine-assisted activities, this research supports that. And finally, what should future research focus on to help us move forward with this population? I think Tim discusses this in his paper at the end, and and he discussed it today, that really looking at things like what other functional activities are impacted by hippotherapy. You can think about this study as more of a basic science type study in that, it's a laboratory setting. The outcome measures are, easily measured in a laboratory setting and easily repeatable, which is always a concern with research, that that the research can be repeated. But anyways, looking at walking or other functional activities, how is that impacted? The young girl being able to stand, how is standing balance impacted? And what else did I put here? The other thing that I think is really important, and again, Tim didn't so much discuss it today, but he discusses in his article, is dosage. We typically see patients in a once a week, 8, 12, 16, whatever a week session. What would happen if we saw patients 3 times a week for 4 weeks? So you do the same 12 sessions, but what happens if you increase the dosage or increase the frequency of the intervention? And, I have a lot of other, I think interesting comments as far as, what other, things can be looked at doing research like this. But anyways, why don't I just hold my comments there for right now, and then maybe I can ask some more questions later. It gives someone else a chance.
Okay, great. Victoria, yeah, we'll come back and see if we have final questions as we get towards the end. Kitty, can we ask you to give your comments?
Absolutely. Thank you, Tim. That was very clear and always great to hear you speak. I'm going to talk a little bit about the broader impact of this study from the more equine-assisted activities and therapeutic riding field and what that impact might have for us. I think the field and anyone who's been working in the field, it has a plethora of anecdotal stories. We know it works, and we have a lot of the one-on-ones. I think, Tim, you made it very clear at the beginning of your presentation that this is research specific to hippotherapy. But at the same time, for those of us in the broader working on a day-to-day basis, we see improvements in functional outcomes simply because a child with poor head stability and poor head control and trunk stability will be unable to hold the reins and perform a half seat, perform basic riding skills, which is my field of expertise in the TR setting. So I think the verification through your research enables us as a therapeutic riding instructor to say there really is this element that's happening that has now been clarified, and all we need to do is expand that research. And I think I would like to ask you perhaps to share a little bit about what you see as the next steps in terms of the broader implications.
Well, I'm an occupational therapist, and a lot of things about this study are kind of a physical body movement kind of a study at the impairment level. What I've been doing since then is the studies that I've had since then, we've also added outcome measures about what kind of changes occur in the lives of the kid or the patient. I think it's not enough to measure things at this basic science level. I think we need to go the next step and really look at how does this affect their lives. Personally as a therapist, I don't care if they learn to ride. I care that the process helps them to be able to do things at home and at school and on the playground. I'm also a therapeutic riding instructor, so if I have them in a therapeutic riding class, I do care that they learn to ride. And I consider the changes at the impairment level to be kind of a side effect of teaching a good riding lesson or having them have a horse experience. But I think that one of the things we have to do is we have to take the conclusions from this study and say, okay, that's hippotherapy. That suggests a hypothesis that it probably is also valid in a riding lesson. But we can't make that generalization, and we need to go further and do some studies of riding lessons, so adapted riding lessons like you do, Kitty, and actually show that those are either equivalent or not equivalent, or they have a certain amount of impact on not just the ability to ride a horse, but the ability to live their lives. And I think that's kind of, for me, the direction that I think we have not gone far enough yet. I also agree with Victoria that a dosage study is important. We have no data whatsoever to say how much intervention makes a difference. We have lots of studies that are all different in the number of interventions they have and how quickly they come and how many times a week, but we just don't have any way to definitively say how much it takes to make a difference and how much we should prescribe as therapists. And we need to know that because insurance companies want to know that. Because what happens often is that people get into hippotherapy or therapeutic riding and it's like forever. And insurance companies don't sign up for forever. They want to know when it's going to end. We need to be able to tell them that so much intervention makes a difference, and after that, we're going to discharge them. We don't have any way to know that except just judgment call one-on-one with each kid. So we need to know those things.
Is there anything that you would suggest in terms of the therapeutic riding setting and recognizing, you've got the dual relationship. as the researcher, as an occupational therapist, as a TR, a therapeutic riding instructor. Obviously, the larger aspect of the field, many of us out there practicing who aren't medical or mental health professionals are looking and cognitively very aware of what are the best practices that we can be providing. Outside of dosaging, one of the things that I intended to ask on the study was there any standardization of treatment protocol through the 12 weeks and through was it one therapist that was delivering service?
No, there were actually quite a few therapists delivering service. So I didn't make any attempt to standardize the treatment. In fact, it's my belief that the treatment needs to be individualized. Okay. I basically turned these kids over to the therapist and said, evaluate this kid and give them what they need. And the therapist made the choice as to what treatment strategies they would do with these kids. And the kids also had a range of impairment levels. So a standardized treatment would not have been appropriate for them.
Great.
And I think that's the way good therapy works, is you evaluate each child independently or each patient independently, and you decide what you have to do for that patient. But what's common among all of them still was the amount of time on the horse and the amount of movement that they experienced while the therapist was customizing their treatment.
Thank you. And I would say an experienced therapeutic riding instructor is able to individualize their lesson to meet the needs of each of those students as well. So
I think you're right. I think they can. But the difference is that the focus of a therapeutic riding instructor is to teach riding lessons. And a lot of these kinds of improvements are a side effect of the lesson, but not the focus of the lesson. Whereas for a therapist, the purpose is to really accomplish these functional and therapeutic goals. And they don't really care about the child learning to ride. So they're really coming at it from opposite perspectives and achieving often similar results.
I would challenge the opposite. I agree with the similar results. I think a experienced therapeutic riding instructor will know that we'll be able to identify when there's a failure to achieve skill progression, that there may be other causes. And I think you're helping us identify some of those things that we can actually target, outside of the medical treatment protocol realm. So I think it's time to turn it to Erica.
I don't disagree with that. I think that a good riding instructor can see balance problems, and they can involve a child in activities that will improve their balance because that'll make them a better rider. So I don't have a problem with that.
Can I add a comment there too? Just that my experience with therapeutic riding as an instructor many years ago, and as a therapist providing hippotherapy, is typically in my therapeutic riding sessions, I wouldn't have a one-on-one session with that child. I would have several, adults, children, whoever was at an appropriate level for that group to work with. And I think that, just as a physical therapist, when I'm dealing with a group of people, it's a little more challenging to come up with individual activities at that moment I guess it's just another difference between therapeutic riding and hippotherapy. And I think it's a little bit more difficult to monitor improvements. And that's not the goal of therapeutic riding, to monitor the improvements that we're seeing that we see in hippotherapy. My focus was more, obviously, control and riding.
Well, I think that's right, and I think that that is what we're trying to accomplish. And I think that there's no doubt that the basic skill level improvements that I measured are probably evident from a therapeutic riding program, but that's not the focus and the goal of a therapeutic riding session. It's more a side effect or an outcome. And I think you're right that when you have 4 people in an arena all in a group riding lesson, you can't individualize quite as much. You put people together that can do the same things because they have to do the same things in the arena at the same time. Otherwise, you can't control it that well. And I think that the other things are outcomes that occur, but aren't the thing that you're really targeting.
Tim, let me switch over and ask Erica if she would give her comments at this point.
Sure.
Okay, thank you. Thanks, Tim. Your presentation was very informative, and the findings are certainly intriguing. And Victoria and Kitty, you've both shared some great comments and questions. One of the things that I hear often across the range of equine-assisted therapies, of which we've sort of commented that there are many, is how do we justify the cost differential between an equine-assisted intervention such as hippotherapy that often requires multiple support staff as compared to that of other effective treatment approaches. In the article it mentions the Swiss ball exercises or sports-related activities, and that those are effective treatment approaches. And so, how do we justify the cost of some of these equine-assisted therapies, both to consumers of our services and also to insurance companies?
Am I the one that's being directed to?
Yeah.
I'm working on trying to develop evidence to justify that cost. I think that's really the goal of doing the research.
Mm-hmm.
I think because of the thing that Victoria mentioned, the amount of repetition that occurs in this kind of a treatment is really an order of magnitude greater than you can accomplish in a typical clinical application. So I think we can show that it's as effective or more effective than other therapeutic activities. But one of the things to consider is that a lot of the things we do as therapists, we don't have evidence for. And we've been doing it for so many years that we don't really have randomized clinical trials of everything that we do. But what we're doing is really not any worse, I guess, in terms of evidence than a lot of other things that typically get paid for. So in a lot of ways, what we're trying to do is come up from a perception on the part of the funders that this is recreational as opposed to therapeutic, as opposed to something that's evidence-based. And I think what we're trying to do is create the evidence base that does that justification. And I don't know how else to do it, because insurance companies, they claim that they make their decisions based on evidence, but when I look at some of the insurance companies' websites and they cite the evidence and say it's still experimental and investigational, I start to wonder.
Yeah.
So we still need better studies. We need bigger studies. We need randomized clinical trials. We need studies that cover dosage and life outcomes and other kinds of things that can really make the difference in justifying that this intervention makes a long-term difference in the lives of these kids and these adults that participate in it.
Tim, you talked a little bit about dosage, and I know there were 12 weeks of intervention in this particular study. Do you have any thoughts about, maybe how long it would have taken to achieve similar results through the other means, such as the Swiss ball exercise, or would the results have even compared?
I give a presentation to the PT department here every year, and I get PT students out in front of the class with Swiss balls and their peers, and I ask them to try to do rhythmic motion on the Swiss ball with these people, and they end up, after 5 minutes, they can't do it anymore, and it's not rhythmical, and they're tired, and you just can't produce that kind of movement on a Swiss ball. And like Victoria was saying, it's really difficult to get the repetition, which is really, I think, the power of the intervention is the repetition. So I don't have any way to estimate it. Most of us that have done this believe that it's more effective than most of those other treatments. But that's where we really need to have studies which not only go longer in terms of dosage and more frequent in terms of dosage, but also we need to have some randomized trials where we're comparing outcomes with kids that are similar, that are going through hippotherapy treatment, and those that are in traditional treatment, and compare those to kids that are not receiving treatment.
Or
that's what's going to be convincing.
Or
have those.
Sorry.
Go ahead, I'm sorry.
I'm sorry. I just wanted to say, have a control group within your study, assigned to, and I know you're not going to be able to get kids to sit on the barrel for 45 minutes, but kids that, have some sort of whatever you can provide as far as the barrel, and have a video in front of them, showing riding through the woods or something, that the control group is just they get the barrel perturbation versus the hippotherapy versus just the standard intervention.
Well, we've actually conducted a study using a fairly sophisticated horse simulator, and to be honest with you, that we were able to show that the movement of that horse simulator in terms of the acceleration using accelerometers had a fifth the power of a real horse, actual acceleration of a real horse. And it only moved in two dimensions, in a sagittal plane and a vertical plane. So it was up and down and back and forth, but no lateral movement. And there aren't any simulators that actually simulate the movement of a real horse, not yet on the marketplace. But I think that the comparisons we need, like I say, are the comparison of kids being individually treated on a real horse, kids being individually treated using best practice in a traditional clinic, and kids not being treated at all and over a long period of time. And or kids or adults, I don't mean just kids. But those are the comparisons that will be convincing. And so far that kind of study has not been done, and there's not been funding for it. And until we get the funding for those kinds of studies, we're not going to be able to have that level of evidence.
Well, that sounds like a good place for us to check back in here. And Tim, I think those are important comments for us to, in some ways, end our discussion on. We need to continue this important research and work towards stronger evidence support for these findings. They're impressive, and I think they're also convincing that research would be important to fund. Before we wrap up here, though, I'll check back in with our panel and just find out if you have any final comments or things that you'd like to say or final questions for Tim. And then Tim, I'll turn it back over to you for last comments, and then we'll close for the afternoon.
This is Kitty, and I just wanted to say I've enjoyed being part of this, and I hope our listeners have too. And I think HHRF will be doing many more of these.
Great, thanks, Kitty. Victoria, any final comments?
Just that I've been out of academia for a little bit, and it's just great to have this interaction with you all. And Tim, I'm just really excited about your research. And I just have one more question. It's just a technical question, but I was thinking about it while you were presenting some of those graphs that you were showing, and just wondering if it would be possible to get more cycles. I know you didn't need any more strength in your analyses because you got statistical significance, but looking at some of your time series graphs, it just seems like it would be really interesting to look at more cycles.
I agree. We actually did 15-second trials that we only analyzed the last 7.5 seconds of them because as we turned up the speed of the barrel, it was inconsistent for the first half of the 15 seconds, and we had consistent speed at the end. There's another question that we could ask: that how well do people respond to changing speed?
Yeah.
I mean, there's a lot of questions we could address here, and how long can somebody sit on a reciprocating barrel, or how long will they sit on it? It's kind of the question, especially kids with CP. I think that, I have all kinds of different variations on this that I would love to pursue.
I bet. That's the goal of Horses and Humans Research Foundation, is to find funding and provide funding to answer all of these questions, because each one of these little studies suggests other studies that need to get done. Yeah.
And we can't do them without the funding. It just doesn't work. So.
And I think your bottom line of changes in the lives of the children, that's right. I think that's going to be really key. And looking at individual results too, because you've got all this data from 11 children. I'm sure they all improved in different ways. you know, so getting to the bottom line of how it affected their lives would be fascinating. Thank you so much.
We didn't have any way to really ask questions about that for this study.
Yeah, of course.
But for our studies since then, we have been asking those questions, and we've gotten some really interesting results which have not been published yet.
Great.
But hopefully those will come out soon.
We'll look forward to that. Erica, any final comments from you?
Yeah, I just wanted to say that I truly enjoyed participating on this panel, and I look forward to reading about future research in hippotherapy and even in other equine-assisted therapies, particularly those that fall higher on an evidentiary hierarchy, such as randomized control trials like we talked about. And I just want to thank you, Tim, for sharing your research.
We're certainly moving in the right direction. So, Tim, we'll wrap up with any final comments from yourself.
I kind of think I've said a lot of the things that I think already, but just to summarize, I think that this is really basic work, and we need to build on it. We need to move in several directions, and like I said, one of the directions needs to be answering the so what question. Okay, so these kids are more stable. What can they do in their life? How does it make things better for them? How are they better able to play with their friends, and how are they better able to have friends? How are they better able to deal with their family as a result of being more stable, and mom and dad don't have to help them so much? And they can do more things, and they can play more games, and they can live a richer life. That's what I want to look at in the future. I also wanted to be clear that while I said it earlier, I want to reemphasize it. We need to be careful of extrapolating the results of this study to everything else that deals with a horse. This was a very controlled, very specific intervention with very specific outcome measures. And I think it suggests the hypothesis that needs to be tested in therapeutic riding or vaulting or driving or those kinds of other areas and see how much change can occur there too. But also we need to be careful about looking at this as an endorsement of everything we do with the horse. And while it suggests that it might be, it doesn't really tell us that without actually studying all of those other different applications of EAAT. So I'm looking forward to the future of being able to do some more of those things, and I'm hoping that this encourages other people to do one of two things. One is to find some money to help some of the studies happen, and the other one is to suggest other ways, other possible grants that HHRF can fund so that we can learn more of these things that we've been talking about and gain some additional evidence that we can provide the insurance companies that make decisions about whether these kids are going to get treatment or not.
Well, thank you, Tim. I think those are good words of caution and important. And I think we'll wrap up here by just saying that, Horses and Humans Research Foundation is really striving to move in the direction of establishing stronger research in this area, both for the establishment of best practices, really supporting programs with information that allow them to say and demonstrate that what they're doing is evidence-based and have a strong scientific and empirical review of these important practices. So there's no doubt about that Horses and Humans Research Foundation will continue to do this important work, and you can find out more about that organization at horsesandhumans.org. So we'll end at this point, and thank you to the panel for your time today and all of your questions. And Tim, thank you especially for sharing your work today.
You're welcome.